Welcome everyone once again. By the time others join, can we quickly have a recap of what we did in the last class? If there are any questions, any doubts, anything you wish to comment. If you remember, we discussed at length about assertive communication skills. Am I right? We saw the videos and also we discussed the different types of communication. And also, I think we all shared our communication skills course, or no?
Yes, ma'am.
We discussed that, yeah. So any questions about the communication style or your scores? Any doubt about that or any?
Ma'am, depending upon the situation, I think we should be able to kind of mix ways of communication. It could be sometimes aggressive or passive or aggressive, passive-aggressive communication. So, are we can we do that or just follow one type of communication all the time?
So, Mr. Vanshi, let me, I know, I think in another program also somebody asked the same question because they felt that aggressive style helps quickly because it gives you short-term results. So it's, it brings the action, quick action. But once in a while, it is a very different thing. Once in a while, it's a very different thing. But if aggression is something I'm using regularly with my team, with my colleagues, then that's not a productive style. Of course, we use all four styles. I'm not saying that we can exclude anyone completely from the toolkit, but then we have to be aware the consequences of each. So if I'm using passive, that means I may not get a fair deal. And if I'm okay with this, I'm okay with this. There's no problem. Passive aggressive is absolutely not helpful because ultimately, more than harming others, you're harming yourself. Because you are cribbing inside and if it is a primary way of handling situation, again, a very unhealthy way of, leading life. And unfortunately, many of us lead that kind of life. We won't say anything on face, but at the back, we will talk ill and, we'll take out our anger and cribbing. Aggressive style, honestly, if you ask me, though we have no 100% control over it, but in the long run, it's not a helpful style because if that is there in my thought process, it's going to come out and then it may come out at a wrong place with the wrong person. I'll have to face the consequences. I may win that situation by using aggression, but then I lose the relationship or the work performance or output of the person. As much as possible, one should use assertion because that gives you satisfaction that you express yourself in an honest manner. That's what is my understanding of the four styles.
Okay.
People who are in higher in hierarchy, they feel aggression is the way to get the work done, but then it's not completely a right way of doing it. It has its own consequences. Yeah. Thank you. Any other question or anything somebody wants to comment or say?
Ma'am, okay. I think we had done 2 surveys. We had answered some questions. Is there going to be any assessment and feedback on that? I don't even remember one of it.
Conflict resolution style, yeah.
Yeah, that competitive shark, the collaborative owl, avoidant turtle.
Yeah. So I tried, though I had that on my mind, but that did not meet well with the topic we are discussing here today, the topic of discussion. So I thought I'll put that on hold. So next 2 topics will be like breaking bad news and disclosure of medical error. So that is where we will try to, integrate that so that you get to see when you are dealing with a very sensitive situation. And if your approach of dealing with the situation is like being authoritative or rude or intimidating, how that can complicate the situation. We'll discuss that. And then I'll show you a small PPT on different styles and what are the pros and cons of each style. We will discuss that shortly.
Thank you,
Definitely we'll discuss.
But there is one question.
Yeah.
As we said that
Yes,
we have to be assertive in our communication. So do we combine spirituality also? Like most of the religious leaders, what do they say that whenever you speak, you communicate with someone, your communication is twofold. Like whenever you communicate something to others, it comes back to you in a reflected manner. Because if you are commanding and the other person will, or you are a fault finding, so the same thing comes to you back immediately, because the person will not respond in that particular way because you talked rudely or found fault in him. So he will find two faults in me. So what do they say, that whatever you say, it comes back to you only. So do we combine all these things?
Dr. Rajesh, I will answer your question. Dr. Sheetal, your device is on unmute mode, and I think you are traveling, so there is a lot of noise coming from your device. If you can keep it on mute mode, yeah. I think Dr. Sheetal, can you hear me? I think she's okay. Yeah. Done. So, Dr. Rajesh, the thing is, spirituality is a very individual belief. For you, it can be a real grounding principle of life. I'm sure many of us may be actually following this rule, that we need to be mindful of our karmas. What we do will come back to us, maybe multiplied many, many folds. But then I can't say others that you need to follow this rule because I believe in this. It can be for you or for me or for many others. But there can be those who do not just believe in something like this. But for them, the idea that assertion will help me put across my thoughts in a clear, honest manner, that will help me achieve the purpose whatever work I'm doing, and also give me satisfaction that I could speak my heart in a very clear manner, is more than enough a reason for them to assert. But yes, more you connect with yourself, more clarity you will have, that in a lot of spheres of life, when you are able to speak honestly and in a very transparent manner with a lot of clarity, it connects you with yourself, and also there's a feeling that there's a power behind me who's kind of guiding me to do my job well. But then that's altogether a different avenue. I would not bring it here because then we'll be kind of digressing from the issue. But definitely, as we grow up, as we become more aware of our own self, these things do come to your mind, and they help you to consolidate your approach in life. Definitely. Thank you for that question. Any other question or thought before we move further? Okay, so if there are no questions about the last session, today's topic of discussion is handing over tools. And I think handing over in hospital or hand off in the hospital has always been a very big issue of concern when it comes to continuity of care, patient safety, and providing quality care. I think we all have concern about it. So if I may share 3 cases with you that I could immediately think of, and I'm sure there may be many more that will be on your mind, and I would like to actually hear from you. What do you say about your experience? So as I said, patient handoff has been a big issue of concern for all of us. So this case that I'm going to share with you is a real life case that I have seen personally. So this patient called Bhim Sen Ahuja, admitted in the hospital emergency with acute MI. So preliminary investigation done, management done, situation was under control, patient was comparatively stabilized, and they were waiting to be transferred to CCU. Meanwhile, the patient desired to go to the toilet. The wife of that patient went to the nurse and asked, the patient wants to go to the toilet, can he go? And in a very casual tone, she said, yes, you can take him. And unfortunately, this patient goes to the toilet and, and in the toilet he collapses. When the nurse was asked that, why did you allow this patient to go to the toilet? Because you knew that, this is a case of acute MI. She said, I didn't know that this is a case of acute MI. And the patient, appeared fine. A life was lost in this case. Another case, patient Rani, again a real life case I'm sharing with you. She delivered a normal, healthy child, shifted to ward after delivery. She complained of feeling of excessive bleeding. She asked her mother-in-law to go and report to the doctor and the nurses, like on that doctor's and nurses station. So it was around 8 o'clock in the evening. Everybody was heading for the shift change. They said, let the next staff come in. We will ask them to see you. Because by then they had already almost like changed to their, civil dress. So in hurry, they forgot to tell this to the next staff. The mother-in-law came once again after almost like waiting for an hour or so. And by the time these residents and nurses went to see the patient had already gone into PPH. All efforts were made to revive, but they couldn't save the patient. And a life was lost in this case also. Another case, recent one. Patient Sunita, a known case of preeclampsia, visits the hospital emergency. The resident on duty, after examining, writes instructions on the patient card. And one of the instructions was injection magnesium sulfate, stat, and then shift the patient to the gynae emergency. Medicine was administered by the junior resident immediately, and the patient was moved to gynae emergency. So since it was not noted that the patient had received magnesium sulfate, the resident in gynae emergency thought that they have to administer it because these were the orders given by the resident from the main emergency. And patient received the repeat dose, went into respiratory distress, moved to ICU. In the whole process, they could save the mother, but lost the baby. So I'm sure you will have a lot of similar stories to share from your experience, from your setup, where things like this happened because of improper handing over between healthcare professionals. Anybody, if has any story to share, any case to share with the group? Any case that you can think of that happened?
Ma'am, this is Vijay here. I'm not from healthcare, but I could see similar things happening, in the basically the IT support side. A person handles the client's case or client's issue, and he does something and he doesn't, properly write down what he has done. And the second shift person comes and, he does something and then the entire system crashes. So these kind of things, we have observed many times because of the lack of proper handoff between the different shifts.
Thank you, Mr. Vijay, for sharing that case. And interestingly, I suddenly remembered one story I'm sure many of you may have heard. It's please take this in a very, very lighter note, but the message that I want to tell you, how important it is to communicate between us when we are looking after a patient, and especially the kind of complex healthcare delivery system now we are dealing with. We really, really need to communicate more efficiently. So this is a story about a father-in-law who got his pajama stitched by a tailor. And that pajama was almost like 3 inches longer than his, required length. So he goes to his one of his daughter-in-law and says कि बेटा मेरा पजामा लंबा बन गया है, इसको थोड़ा छोटा कर दो, 3 इंच लंबा है, इसको नीचे से काट के छोटा कर देना. She said, ठीक है पापा जी, मैं किचन में हूँ, अभी काम करके मैं कर देती हूँ. Everybody understands Hindi?
Yes.
Thank you. So and she says कि okay, I'm right now in the kitchen. Let me get free. I'll do it. He was in hurry. He had to go somewhere. So he went to the second daughter-in-law and he said कि बेटा पजामा बनकर आया है, लंबा है इतना सा, तो थोड़ा सा छोटा करना है, तुम काट के सिल दोगी, छोटा कर दोगी. तो कहा पापा जी रख दीजिए, बस मैं 2 मिनट ही कपड़े धो रही हूँ, कपड़े धोकर मैं अभी कर देती हूँ. He said कि nobody is free. Then he goes to the third one and she also was busy with teaching her children or something. So ultimately, he got so bugged, he said, "Theek hai." He left it in the drawing room, saying, "Ki jisko time milega, kar dena." 4 बहू थी उनकी, 4. So जैसे जैसे जो फ्री होती गई, उन्होंने पजामे में से 3 इंच काटा और सिल दिया. जब पापा जी बाहर से वापस आए, so this is what happens when there are too many cooks, and if they don't communicate, this is what happens. Unfortunately, we can laugh over it, but the seriousness of the issue is actually very heartening. Trust me, I'm sure personally you also may have experienced something like this when your patient or your family member got hurt because the healthcare professionals did not communicate effectively between them. Especially because we know healthcare is a 24/7 service. Patients are going to be in the hospital or under your care. Staff is going to change. Staff is going to be, in rotation. So how critical it becomes to give the information in a manner that is clear, understandable, complete, accurate, timely. A lot of time you'll see information is neither not complete, nor it is timely, nor it is even accurate. So as a result, there is a lot of chaos that you see. Anybody has any experience of first-hand experience of something like this that happened with you or happened like that's in your knowledge from your setup, where something like this you saw? Yes, Mr. Mohan, go ahead, please. Yeah.
My wife was pregnant with our second child, and she had an attack of bronchial allergy because she had dusted something, and so she was hospitalized for about 3 days. And on the first day of hospitalization, she had to be administered steroids. And it so happened that one of the nurses had given the dosage, but had not entered and quickly went on to attend to some other patient. Meanwhile, another nurse came and gave the second dose. My wife was on sedatives and she didn't realize that the same medication was being administered. There was a little bit of complication, but all went on well finally. Yeah.
So even if there is no, yeah, exactly. Even if there's no complication, that mental stress that I have received a double dose.
Yes, we lose confidence in the total setup.
Absolutely, absolutely. You fear that you can be harmed again, and there's something like this can actually, go in. And actually, that's one area where most of the hospitals are struggling very badly. I mean, before I actually show you the slides further, I want to ask you: are you satisfied with the way handing over takes place in your setup, especially those who are actually in direct patient management, or you are in the administrative position, but you get to see a lot of cases like this. I think Dr. Puneet Gupta says yes, you are satisfied. Am I right, Dr. Puneet? That's what you're saying?
Yes.
Okay, that's wonderful. But Dr. Praveen says that no, I am not. Dr. Praveen Monga also says I'm not. Because I think more the number of people involved, more chances of error. If it's a single, a person's practice, it's easy to keep a control on the flow of information because you have control over all the information, and you will make sure that you can control it. But when you have so many people engaged and involved, naturally, I can see, there is all possibility of error in care because there's no proper communication. For example, Dr. Praveen Monga says, yes, lots of improvement required. I absolutely agree with you. Then Dr. Praveen from HMC Hospital says insulin administration is a common problem. Yes, sometimes given double and not given food, and sometimes given food and not given medicine, sometimes given more dose. And sometimes patient is not even instructed that if you are not taking food, then please don't take this medicine. This recently happened with my brother. He was unwell. He had severe gastroenteritis. He went to his doctor. He wrote all the medicines, but he did not communicate to him saying that in case if you're not taking sufficient food, then you need to really regulate the medicine or maybe skip the dose depending upon the blood sugar level you have. And then he missed a couple of his meals because of loss of appetite and then stomach upset. On the other side, he had, loose motion, and then he fell. He literally fainted. And when they checked his sugar, it was 40. So imagine the kind of errors you get to see just because when we are not communicating effectively, how it can actually harm the patient and compromise patient's safety. So actually, if I tell you healthcare is considered, healthcare patient handoff is actually identified as a critical safety and quality problem. To the extent they call it as Bermuda Triangle of healthcare. Most of the information gets lost when the patient is moved, not literally, but handed over from one care area to another. Because it's only during transition, the person who was caring is not able to communicate a complete information to the next person. There's a risk of losing the information, compromising patient safety. So a study was done by JCI where around 3,000 sentinel events were studied. And it revealed 65% of the sentinel events were because of the poor communication, which actually became 70% in the next year. And 50% of them were actually during handoff. So you can well imagine the seriousness of the issue and the way it's being handled all across. Studies that show us what would actually work or what will not work, that of course we'll be talking in a while, but then we all know that ineffective handover can lead to things like wrong treatment, delay in treatment, severe adverse events, patient complaints and complications, increased healthcare cost, and increased length of stay. And I'm sure you all must have experienced this personally, or at least may have seen this happening in your setup. So in a recent study in 2016, again, this study estimated that almost like in 30% of the cases of malpractice, communication failure was the lead reason, which resulted in almost like 1,744 deaths and around $1.7 billion in malpractice cost in 5 years. So you can see the seriousness of the situation. Again, I don't think we have made any effort to actually assess. I don't know if there's any study that shows how much do we lose on that front if we don't hand over effectively, any study done in India. But if we go by what is happening across the world, we get an idea that things are really, really not, in good shape. So if I may ask you a question, what challenges have you experienced in your setup around effective handover, leading to lapses in care? Write in the chat box. So what challenges are you normally experiencing on that front? If you can share your thoughts. Patient dissatisfaction. Yes, absolutely. Okay, you want to see this slide once again, Dr. Rakshita? Is that okay?
Yes, yes.
Yes, I can see a lot of answers coming from all of you. Yes, seriousness of this staff involved is a challenge. I completely agree. Litigation, yes, we do hear now cases. More time taken, definitely takes long time to finish a job properly. Definitely, if you don't have complete information, definitely all that leads to, plus the lapses in care. Either the patient is, patient receives double dose or misses the dose or is not. Wrong site surgery, wrong organ removal, wrong patient, wrong medicine. I think these are all common things. A lot of time when it is not communicated effectively from one care area to another care area. Why do you think are we facing this problem? Yes, loss of trust, absolutely. And branding reputation. I agree with you, Dr. Rakshita. Are there more answers? Yes. Not using structured handover. Yes, I think that's major problem, that we are not using any, though we have couple of them available, but we somehow feel that no, it's okay to just verbally communicate whatever we think is important. Barrier in communication, yes, they are problem. Poor quality staff due to poor payments. Yes, I think that's there we are going deep down.
This is the main reason of poor quality of services, because in India we are not paying our staff adequately. 5,000 rupees we pay to the nurse, and then we expect she should work for 8 hours or 12 hours. How can you expect? The patients are not paying adequately. How can you pay to the staff? Most of the hospitals, the problem is this, even in the best of the hospitals in Delhi.
I completely agree with you. So again, if I will go looking for the problems, I'll have 110 reasons to say why we are going wrong. But in our place, how can I make things better? That's something we really have to, focus on, because that's what is going to give us results. If I talk about the problems, it's endless. I completely agree with you. Yes, if you have unqualified or underqualified staff, this risk is always that you're taking, that your staff will not be even knowing. Like, for example, this nurse who allowed the patient to go to the toilet, the patient who had acute MI, she didn't know that this patient is of MI. I don't know if she knew that this patient is of MI, she would have allowed or not. I am not sure. But then I agree with you that this is very common. So what other challenges, or why do you think are we still struggling with handoff as a problem? See, when I ask nurses, how do you handle it?
Sometimes, ma'am, what happens? A new Keralite nurse comes, and we give them instruction, and in Hindi or English, whatever is the language, and she says yes, and we think that she has understood everything, but actually she doesn't even understand whatever you. So these are the problems, and you cannot. There are certain things you have to communicate verbally. You cannot write everything on the paper or case sheet. This is one.
So, Dr. I think we discussed one point. I think at least from this training program, you can pick up tips how to really, close the loop. So if you remember, we discussed about one point, and that is called teach back. So next time you train your staff and she says, yes, I've understood. Now, staff or a doctor or anybody, and they say, yes, I've understood. Okay, tell me in your words, what have you understood? You will get to know how much the staff has really understood. And also, we did talk about, facilitation skills. So I made a mention that more audiovisual aids you will use, more it will improve the learning of the person. So if what I'm saying, if I can show in black and white, if I can show in a book, or if I can show in a chart, they'll understand what is expected from them. So language is a very big barrier. I completely agree with you. But this challenge we are going to continue facing. But at the same time, if you look at medical tourism, we are getting so many patients from the neighboring countries. And I was surprised. I went to one of the eye center for a training program. They had invited me to, to train their staff, to do a session with their staff. And I was in their, waiting area in the guest room. And there was a patient coming from a neighboring state. I think, I don't remember exactly which place. And there was a counselor. She had a, translator in her hand, and she was communicating with that patient very effectively. What I'm trying to say, where there's a will, there is a way. We know medical tourism will get us more patients and more money. We find out ways how to communicate even with those patients whose language is completely unknown to us. But then anywhere, if patient's care is compromised or patient's life is at risk, I think we need to find a way to make sure that that does not happen, because any lapse would be our responsibility. We will be legally, in trouble. So I agree with some of the answers that you have given. Casual approach to work can be, and also not knowing the importance of handing over. So for example, when I ask nurses, how do you hand over? So most of them, they'll say, we do it very meticulously. We go from bed to bed and we hand over the patient to the next staff. Then I'll say, okay, in case if the next staff is late, then where do you hand over? They say, ma'am, if the next staff is late, then we will, do the handing over in the nurses station. We'll stand there and we'll open the transfer file and we'll start telling them, okay, this patient has this and this. I said, in case the next staff comes further late, because we know people normally would come exactly at the time that they're supposed to be coming. So if she comes further late, then what do you do? Then they says, ma'am, then we do it in the changing room. We simultaneously keep changing our dress and then also keep telling about each patient, whatever important has to be said. I said, in case if the next staff comes further late, then what do you do? She says, then it's at the gate. We say, I've written everything in the case sheet. In case if you have anything that you don't understand, call me. That's all. You can message me. That is actually the handing over happening in most of the places. And when I asked doctors, how do you hand over? How do we hand over? Any idea?
They normally communicate to the resident doctors.
And कैसे कहते हैं, ये सब ठीक है, ये दो को देख लेना. शाहरुख कह रहे हैं वर्बली. यस, शाहरुख वर्बली ही कहते हैं और उसमें भी ये कहते हैं ये सब ठीक है तो ये दो को देख लेना. तो जो रेजिडेंट ऑन ड्यूटी आ रहा होता है उसको पता है बस यही दो पेशेंट है जिनको हो सकता है ये खपती है, हो सकता है डिमांडिंग है, हो सकता है इल है, मतलब पर ये पता है कि अटेंशन ये दो को जानी है, बाकी सब ठीक है, उनको कुछ करने की जरूरत नहीं है. और अगर उनसे कोई कंप्लेन आएगी या कोई रिक्वेस्ट आएगी तो दैट्स नॉट इम्पोर्टेंट, बिकॉज दैट्स हाउ वी ट्यून आवरसेल्फ. So some of the issues and dilemmas with handing over as a challenge is because still it is being done in a very, very, unstructured manner. For example, we don't have proper protocols in a lot of places. I'm sure a lot of corporate hospitals have a proper system. They have electronic system of actually handing over and taking over, but that's more theoretical. Again, everything is there in on the system, but who knows actually? And it's usually a one-way communication. If I'm entering the information on laptop, on my iPad, for somebody to read later, that means that person cannot come and ask me if they have any doubt. So it's mostly an unstructured one-way kind of a communication. There is extreme variability and uniqueness of handoff and transition in different areas. Now, for example, a transition or handoff in a simple ward, like, for example, medical ward, a simple case of viral fever will require very little information to be handed over or to be taken over. On the other side, patient in the CCU or ICU or any other critical care area, there probably the complexity of the information is so much so that it becomes very unique to that particular area. And therefore, there is extreme variability from very simple communication to very complex communication. And then the frequency with which this thing is being done in each hospital, almost like 4,000 to 5,000 handoffs every day. So imagine the possibility of, errors. And unless it is really standardized, how the whole communication can go haywire. Another important thing is time, commitment, and process change. If I may ask all those who are practicing handing over in a real sense, have you established any common time between the two staff members who are going to exchange their roles? The one who is going and then when he comes in. Do you have any overlapping time between them?
We usually ask the nurses to come 15-20 minutes earlier so that they can have that overlapping time and then they can communicate, sometimes half an hour, so that there is a proper
Mr. Mohan, do they come?
Sorry?
Do they come?
Yeah, maybe I can say 70%, but
if you ask me to come 15 minutes before my time, why will I come if you have not put this in the roster that my timings are not 8 o'clock, but it is 7:30?
Yeah, that is what.
If it is on the roster,
we put it in the roster.
So if it is, No, yeah, if it is there in the roster, then definitely they'll know that they are supposed to be coming. If you're doing it, then it's fantastic. But mostly it's just, we expect them to be coming, 15 minutes before or staying 15 minutes. So if I consider a ward with a patient of say 40 patients, at least a minute or 2 minutes of handing over per patient. Reasonable? That means at least 40 to 50 minutes if I really want to take over or hand over a patient bed to bed. Minimum I'm talking about. So at least it's 1 hour job. And incidentally, nowhere, I mean, very rarely I see any hospital having a very clear-cut defined overlapping time in all 3 shifts. That the staff who is coming will be coming at 7:30, the staff who is going will be going at 8:30. And their duty timings are accordingly. So we all know the reality is that still we do not have that kind of, commitment to handing over as a important critical activity in the hospital. It's assumed that it is being done properly. How many of us have gone and supervised the handing over and taking over? So like I am an assessor with NHSRC, and we did a virtual assessment in those days when we had COVID situation and we were not actually physically visiting the setup. So we said, you haven't given any evidence of bed-to-bed handing over. So they made a patient lie down, and then one nurse was standing and the other nurse was, speaking. So that is the evidence that they produced, that okay, this is what is actually happening. But if you go and really see in real sense, I really doubt if there is any proper handing over, even on document. So we all know that there's a lack of commitment, especially the overlapping time that I'm talking about. I haven't seen in any hospital being done, very meticulously. I'm reading your comments, Dr. Praveen. It says, no, the incomer comes early, okay, but not always because of 8 hours of work time. Absolutely. See, anybody who is asked to, stay more than 8 hours, why will they do unless we have a, way to give them compensation for that or some relief for that? Yes, but happens properly when supervisor is around, otherwise on paper. Absolutely. I think you are right. So that means if you are there, then definitely they will also be. But how many times can we supervise? And where all can we supervise? Yes, we are talking about shift overlap, Dr. Himanshu, and that's what we are discussing. How many hospitals have this, in place, shift overlap? Do you have this in your hospital? Dr. Himanshu, do you have this? No. Dr. Praveen says no, but what about Dr. Himanshu?
Yes, ma'am, we have since beginning. And
okay.
We have
so how are you?
We have a huge advantage of it.
Okay. And how are you running it? Like then how many hours each staff has to be in the hospital?
So the night shift at our place, because the hospital is situated outside the city limits. So the night shift at our place is of 10 hours.
Okay.
So all are working two morning shift, 2 evening shift, and then 2 night shift. So the overall working hours remains 24 hours. If we see the weekly calculations. So that's how we have scheduled that there is an overlap of an hour.
Absolutely. So that means if you will want to do it, you will find a way to do it. That's what we are discussing. You joined just now. So that's what we were trying to discuss, that we do not have that overlapping system in most of the hospitals. So as a result, why will staff stay beyond their duty hours? Or why will staff agree to come much before their duty hour? And we also calculated that almost it requires 1 hour of overlapping time if we want to seriously do bed-to-bed handing over of say 30 to 40 patients. And that's what we were trying to discuss. Thank you for sharing your experience, and that tells us that okay, if you want, you can find a way. That's true. So we all understand that unless there is a commitment, unless there's a time commitment, unless there's a process change, you will actually not be able to implement handing over in the real sense. Otherwise, it will remain a paper activity, which actually is in most of the places right now also. And also, we haven't done any, research focused research to see the ill effects of improper handing over. We are just going by hearsay, or whenever we face a situation, we see, okay, this is what happened because it was not properly handed over. But we haven't done much study to understand what are the consequences. There's a study that I would like to share with you to find out what is the best way that will work. So what they did, they took 12 simulated patients and they were handed over in 5 consecutive cycles. And they used 3 different styles. In first style, it was just verbal handing over with no written document. In this second one, it was written handing over and no verbal communication. In the third one, they combined both, where they had a standardized form with verbal handover. And results showed that verbal handover resulted in loss of almost all the data, because we forget when we get engaged with something, and then we may miss on something very important. The example of that case that I shared with you, where we lost that lady after delivery, just because when she complained of excessive bleeding, the staff who was going, she said, I'll inform the next nurse or the next resident, and he or she forgot. And by the time they got to know, we had already lost the patient. Second is note taking, which again resulted in 30% of the data. So in case if you have a system where the staff is supposed to be adding everything on the electronic medium, it's good that you have everything on record. But then how many times do we really go and reach each record once we get back to duty? It's only if there is important, somebody points out, we go to the patient's case sheet and read the notes about the patient. So this also led to almost like 30% of the loss of information. Standardized form and verbal handover, when they were combined together, that led to minimal loss. So I think that's the format we have to ultimately follow in most of the places. Dr. Monga wrote a very beautiful point. Handover is not given. Handover is taken. Absolutely. And that has to be the approach, because after you take over the patient is your responsibility. If anything goes wrong, it's you who did not do things right. If the person has gone after handing over and you did not check the information, you did not collect the information, and if anything happens, then it becomes your responsibility. So handoff is not passing the buck. Actually, it's passing the torch. So a lot of time we think handoff is boring, monotonous, unnecessary. So it's done more like a quick down and dirty exchange of few facts. That is, patient का ये करना है, इसका ये करना है, इसकी report भेजी हुई है, इसका referral भेजा हुआ है, इसको empty stomach रखना है. This is how we normally do it. But it requires a more coordinated effort among 2 professionals. Because both the giver and receiver of the patient information have important responsibility. The one who is going is responsible to give the information that this is what happened in the last 8 hours or 6 hours in my presence. If patient had pain, patient had bleeding, if patient lost consciousness, or the blood sugar level went up or low, that has to be communicated to the next person, because the person should know what can I anticipate in the next 6 to 8 hours. And each party has to be comfortable with the information exchange. A lot of time we see when a nurse is handing over to the other one, if the other one is very experienced and has been there for years, she'll say, "Tu jana, mujhe pata hai what has to be done. Don't try to teach me. I know what needs to be done." So a lot of time you cut them down and you don't let them speak. So it has to be done in a very responsible way. It's more like, painting a picture. So what you have seen, the next person hasn't seen. So you have to literally, kind of paint a picture, give all relevant information, give specific direction with rationale, and then also check for understanding. That's the responsibility of the sender. On the other side, the receiver is responsible to make sure that receiver listens attentively. So as Dr. Monga also wrote, handover is not given, it is taken. So if I'm listening attentively, if I don't understand anything, I'll clarify. If I have a question, I'll ask questions. I will also have a copy and a pen in my hand where I'll be noting down at least all the important information that I really need to focus immediately after the handover. For example, if I need to get the reports from the lab, or if I need to send a reminder for the referral, or if I need to, check patient's details or whatever. So that can be, separately noted down so that I know this is something I need to immediately work on. And then, of course, read back. Very important to make sure that have I really understood, or is there any communication gap. So if I go by the definition of handoff, it's a transfer and acceptance of patient care responsibility. So it's not just transferring, it's also that I'm accepting the responsibility through effective communication. So it's a real-time process of passing patient-specific information from one caregiver to another, or from one team of caregivers to another, for the purpose of ensuring continuity and safety of the patient. This is the definition given by JCI. I think it's a very simple and to the point kind of a definition. I think we really need to learn the concept of handing over from industries like nuclear power, aviation, dispatch services. Not that they're more intelligent than us, but I think they're more organized than us. They're more systematic than us. You will hardly receive a packet that does not belong to you. Or it's considered safer to work in nuclear industry or in aviation than to actually work in healthcare or get admitted in the hospital. 1 is to 33,000 errors. You can well imagine. And I think we really need to learn, why do we, fail to communicate to the next person. Now, if I talk about the types of handover, what are the different types of handover do you normally see in that are normally seen in healthcare? Are you writing in the chat box? No, I'm not asking about the verbal or written. I'm asking about types of handover. Like, for example, we see handing over between nurses. So that's one handover. Then between whom all do we see commonly this kind of handover? Nurses, RMOs.
Between
yes.
Floor doctors.
Between?
The floor doctors or the duty doctors.
Yes.
The resident.
Between residents, absolutely. I mean, if one is relieving and the other one is coming in, so definitely they need to hand over. Yes. Front office, yes. When they are sending the patient to a ward or to any department, so they are supposed to be communicating with them. Support team, yes. Now, for example, the patient is being sent from one care area to another. For example, the patient was in ICU and now the patient needs to be moved to ward. Again, there is a handing over. Or from OT to ICU. Again, there is a handing over. From one specialty to another. For example, the patient was admitted in orthopedics and patient is fine now and needs to be moved to medicine now. Or the patient was in medicine and now it is decided that the patient requires orthopedic intervention. So the patient needs to be moved to the orthopedics. So from one care area to another care area. Between doctors also, there can be exchange from one specialist to another specialist. Yes, in lab also, whenever you have critical report, you're supposed to be informing the patient to get in touch with the doctor, and you're supposed to be informing the doctor about the critical report so that an immediate intervention can be made. All that is part of actually handing over. So we all are familiar with the regular handing over that we get to see, and that is, we think it is mainly between nurses, but there are many other areas where actually handoff takes place. For example, level of care from OT to ICU, ICU to ward, doctor's shift change, yes, physician transferring care from one care area to another care area, patient transferred in and out of the hospital. Again, a lot of time you will see the information that goes with the patient is not actually complete, or in the real sense actually communicates everything about the patient. Then On-call responsibilities. For example, there are people on call who needs to be called in whenever required. Even that's a way of handing off, because you are kind of sending a referral call to the patient. A lot of time we refer the patient from our setup to a bigger hospital. I have seen number of times referral slip as refer to gynae department, refer to psychiatry department, refer to medicine department for assessment. But what exactly it is? Is it complete, or is it just one line? Then of course, critical report that we said we need to inform to the concerned doctor and also inform the patient to get in touch with the doctor. Then hospital transfers from one care area to another, and also within the hospital, when you're sending the patient from your department to radiology or physical therapy, even that is called a handoff. Now, if I may ask you, what do you think are the minimum components of an ideal handoff? Right in the chat box. What all should be part and parcel of the handing over from one person to another? Yes, Dr. Himanshu, I agree. Purpose has to be specified when you are sending a referral call. Absolutely, I agree. Okay, any criticality to be handled? Okay, that can be one of the. So what you can anticipate, yeah, that identity of the patient. Yes, what is the, who is this patient? Absolutely. And what is the purpose? So if I may just take, it's a handover between two doctors in the same area. There's no change of care of area, or between two nurses. So what all should be at least communicated between them when they are handing over the patient? Medication given, yes, that's an important part. That's important part. Or to be given, yes, that's also part of the communication. Treatment plan, yes, very important. What are you planning? It could be you need to keep this patient empty stomach for a investigation or for a procedure tomorrow. All that has to be part of the communication. Patient's detail, treatment required, investigation pending, next checkup of the vitals. Yes. Escalating signs. Yes. If there's anything to be concerned about. Yes. And then immediate risk involved in a particular patient. Yes. If the patient is diabetic, hypertensive, bleeding, in pain, so that needs to be definitely informed. Medication and future treatment plan. Yes. Then reconciliation of medicines. Absolutely, I agree. And then on-call consultant. Yes. So that means almost like everything has to be communicated in a very concise manner. And for that, we really require a proper communication tool. Of course, we'll be talking about some tools that are being, being used or being recommended. This activity I normally give to the participants when we have kind of a full day program where I'm talking about the essential communication skills. So I give them this activity and I ask them to write at least 10 things that you think are important from your point of view for ideal handoff. And then I make them do this as a group activity. So usually these are the things they are able to identify that should form the component of an ideal handoff. Excuse me. Of course, this is a very basic one, very, very basic one, but this covers almost all aspects of patient care, but you can always, modify. Once you will get something like this done by your hospital staff, trust me, their commitment to handing over actually becomes more, serious, because then they realize why we need to talk about all this. So I think if I may just summarize this, patient's handoff should include patient's condition, care, treatment, medications, services, and any recent or anticipated changes to any of these. So that will automatically cover almost everything that we need to hand over about the patient. I'm showing you a case here. And if I ask you to put little emphasis or little more attention to the line that is underlined, the statement that is underlined, what is your understanding of this case? So you think that you are a you are handing over to your fellow doctor or fellow nurse. And this is the case. Kishore, 14 years old boy, admitted 2 days ago with acute asthma, triggered due to URI. He's improving and most likely going home tomorrow. So nothing much to be done. Is still on an oxygen, little oxygen. Just try to wean it overnight so that he can actually go home. So what do you think will be the important message that the person who is receiving will register? Okay, too casual, bad time to win. Okay, so you have started analyzing the handing over. That's fine. I completely agree. But I said, if this was being said to me that this patient is getting discharged tomorrow, so what is going to be my way of looking at the case? I'm trying to bring your attention to that point. Okay, that there's an effort to send him off. So the moment somebody tells me this patient is fine and is going to go tomorrow, do I really make any serious effort to work on that patient? So that means it's normal, nothing to be done. There's no need for any review. So here comes a risk, and that is that there's a possibility of, yes, you're right, there's lesser need for care. And there's a possibility of something like selective attention, selective listening, and selective forgetting. Just the moment you get to hear something like this, that this patient is fine and is going to be discharged, or you get to hear, oh, this patient is very demanding, or this patient is very troublesome. A lot of time we have the tendency to label a patient, oh, this patient is complaining a lot. He doesn't have much pain, but he's really making a lot of noise. So when you hear something like this, there's a possibility that we get into the process of cognitive, selective listening, selective attention, and selective forgetting. So if I may show you the next slide, it's something like when we are talking to our pet knows its name. So the owner of this pet is talking at length. Okay, Ginger, I've had it. You stay out of the garbage. Understand, Ginger, stay out of the garbage. Orders. But what is Ginger understanding? Ginger, Ginger, Ginger. And that's what is actually selective listening, selective, attending. So let me show you a short video. And in that video, just 1 second, let me quickly first open the video. It takes a little time to.
I've been getting paid $1,000 a month. This is a test of selective attention. Count how many times the players wearing white pass the basketball. How many passes did you count?
So how many passes did you count? Could you count the number of times people wearing white handed over the ball to the next one? 11. Okay, Dr. Praveen says 11. 10. Dr. Richa also says 10. Okay. Have you seen this video earlier? Anybody who has seen this video earlier? No. Okay, Dr. Azad says 10. Okay. Then? Okay. So Dr. Rakshita, I think it's okay if you have seen, but we are not going to, I would request you to keep quiet. So 11, 10, 10, 10. Okay, what about others? Did they count? Or they couldn't count? Okay, did not count. Okay, it's all right. I understand. So the answer is actually 15. The correct answer is 15. But let's see it further.
The correct answer is 15 passes. But did you see the gorilla?
How many of you saw the gorilla? Okay, Mr. Mohan sir, how about others? Anybody? Yes or no? Okay, let's see it once again.
This video is from research by Daniel Simons and Christopher Chabris and is copyrighted.
So this is what exactly happens once we are so engrossed into something that we don't see the total picture. A lot of us miss the gorilla. And you may have been surprised that how could we miss this? So that's the cognitive process. When we are focusing on something, we tend to overlook the surrounding. So this is what exactly happens even in handing over, when we are not, we are not listening to the whole thing, but we are focusing on only thing that is being said to us. Okay. So this is a very simple handing over tool being used in a lot of places, but I think it's most easy to implement where things are very simple and easy to communicate, and there's no complex information or no complicated information. So this is called rule of 5 P's. So what is rule of 5 P's? That is name of the patient, plan, what is the plan of action, what is the purpose of the plan, and then problem and precautions. For example, this is patient Ram, 54 years, to be kept empty stomach for barium meal test. He's diabetic, so check his blood sugar every hourly to avoid hypoglycemia. So this is something very, very simple and easy. Now, if I may ask you to use this rule of 5P and hand over the next patient, this patient that we discussed just now, Kishore, a 14 years old boy with this. So can somebody try? How will you hand over using 5P? You could unmute and speak. It's okay. I can. Yes, please go ahead. Do you want me to show the slide once again, Dr. Azad? I'm not able to hear you. Do you want me to show the slide once again? Okay. Okay. Give me a second. Yeah. Yeah. So you can write in your notebook and then one of you can, share what you have written. So can I stop sharing? Because only then I'll be able to interact with you. So anybody who is ready with the handing over with 5 P's? Do you want me to write 5 P's in the chat box? Okay, give me a second. Let me. Let me copy and paste it. Yeah, I've written in the chat box. And if anybody is ready, you can unmute and speak, please. Anybody ready?
Patient is Kishore, 14 years boy.
Okay.
Plan is to win him off.
Mm-hmm.
Purpose is to discharge him to go home.
Mm-hmm.
Problem is his medical condition as minor. And then precaution to win him properly.
Okay, good attempt. Thank you. Anybody else who has something different from what Dr. Seema has shared? Now you see what happens if we are using this simple style of communication. Now what will happen in this case? You have talked about the 5 P's, but a lot of information still needs to be discussed. For example, about medication, nutrition, then oxygen requirement, and also the infection, for which reason the patient actually came in, and then also the contingency plan. So that means this 5P style of communication is also very basic and is insufficient. Now, if I may ask you, what are the barriers to effective communication? Can you think of the barriers? Why are we not able to communicate effectively when it comes to handing over? What are the barriers? Lesser time, more patience. Okay, agreed. Very right. Time constraint is one of the reasons. Language is a reason, absolutely. Preoccupation is a reason. Language, again, understanding, absolutely. Using of media and words. So Halal, if you can explain in your words what exactly you mean by using of media and words. Can you explain?
Okay, ma'am. The way we communicate with the person is like in our institution, we have 4 or 5 people in our department. When you use to our local language, like our local language to communicate the problems, it would better for us to communicate actually. And when we used to write it in different language, it becomes very difficult to understand the language actually. That is why most of the time we prefer to communicate in written format, and sometimes if we want to communicate in verbal format, we use the local language actually.
Okay, I get it. Yeah, thank you so much. So definitely that means language is a barrier if it is not effectively used, and if you're not careful that the other person should understand the language you're speaking. Lack of good relation between the two. Very right, Dr. Talwar. When 2 doctors, 2 nurses, or a doctor or a nurse don't enjoy good rapport, they will not communicate. They will not share information. They may not even listen to each other. They may actually kind of snub the other person. Don't try to teach me. Yes, Shahrukh, very right. Ego. Lot of time when a resident tries to communicate to the consultant, it comes as an ego problem. Or a lot of time when nurses try to communicate with the doctors, they may think, who are you to tell me about this? Then overestimating our efficiency, yes, thinking that, okay, you should be able to do everything, not realistically planning that, okay, this is what a person can actually do. Absolutely. So that means there are a lot of challenges and a lot of barriers. So one that we discussed was like cognitive process of selective listening, selective attention. Similarly, there are many more barriers that come in the way of effective handing over. So for example, one is the complex system. It's not as simple as 5 Ps that we discussed just now. There's so much more. Technology every day is improving and increasing. That book by Atul Gawande that talks about the checklist manifesto, it clearly says the kind of information you all are dealing right now is practically impossible for human brain to process and keep updated. So unless we have systems in place that can actually take care of all this, it's very difficult to practically remember everything. Then of course the second one is the volume of information. As I think I mentioned in one of the sessions here, in an ICU, on an average for a patient, there are 178, ins and out about that patient. So imagine the volume of information, which is practically not possible to communicate completely. Time constraints, as many of you have said, that unless there's an overlapping shift, there will always be this challenge. And even if that overlapping shift is there, actually practically talking about every patient becomes sometimes very, very challenging. Then limitation of learning and training. So for example, if you have worked in a setup where there was no handing over, taking over, it's going to be a great challenge for you to understand that I need to hand over and take over. If I may talk about the doctors, most of the doctors have not been trained in institutions where they learn to systematically take over and hand over the patient. They have great challenge in accepting that handing over and taking over is not just nurses' responsibility. Even doctors are supposed to hand over and take over patient with equal seriousness and attention. Then of course, there's continuity gap, especially when the patient is being moved from one care to another care area, or in the same area, it's not same set of people who are looking after, there can be community gap, continuity gap. Then human fallibility. We forget, we don't remember, we lose attention, we get occupied. These all can be, these all can interfere with effective communication. And then negative impact of fatigue. A lot of studies have shown that when we are tired, our attention span, our concentration, our ability to memorize becomes a challenge. Then confidentiality. A lot of time we have information, we don't know whether I should be sharing or not. So that becomes a barrier to communication. We all have different styles of communication. We have talked at length about different styles of communication. Some people are good at verbal communication, some are good at documenting it, but that becomes a communication barrier when it comes to actually communicating to the next person. For example, if I'm not fond of explaining about things, I may have challenge talking about each and every patient and explaining about the patient. Language, we all know, is a big challenge. I think we have around 720 dialects in our country. So imagine how something can go missing, especially when you don't understand it exactly. Cultural background can be a barrier. Hierarchy of decision making, as we discussed, that if I think that's not my prerogative, that's the prerogative of the consultant, then that can come as a barrier, that I'm not supposed to be interfering in this. It's the doctor's responsibility, or it is the consultant's prerogative. Then level of respect between physician and nurses. In a lot of places we see they don't enjoy same level of respect between them. At places we have seen physicians snub nurses, and they don't like them telling them anything or reporting them anything. In a lot of setups we see senior nurses snub interns and residents because they think we are here in the system for years together, so you're not the one who's going to tell me what to do and what not to do. So this kind of conflict between the doctors and nurses definitely affects easy flow of information between them. And then of course level of empowerment, where we have not empowered our staff to speak in a very open manner, in an honest manner. A lot of time they will have information, but they will not share, fearing that I can be shouted at or somebody can be rude to me. Even among doctors and nurses, I'm sure you must have seen these challenges. There's a difference in their style of communication. Some speak very little, some speak to the point, some don't like to speak at all, some don't make eye contact. So hierarchy is a challenge, we all know. past experience with the person. If this person has ever snubbed you or shouted at you or misbehaved with you or has ridiculed you, the person will lose confidence to report ever in future about any patient. Then things like level of empowerment, tone of voice. If your tone of voice is rude, authoritative, intimidating, your staff will never be comfortable talking to you and telling you about a case or a patient. This we have talked about. Language we have talked about. Now coming to various tools of handoff that we have heard of. So if I may ask you, are you familiar with a couple of tools? And if yes, then which tool have you used or you're familiar with? Right in the chat box. SOAP, okay. S-bar, okay. That's good. I think S-bar almost everybody must have come across and may have used also. Yeah. Okay. A, B, C, D, E. I think I read it somewhere. Can you explain, Dr. Sheetal, this one? A, B, C, D, E. Are you comfortable?
Yes, ma'am. Yes, ma'am. I'd like to, yeah. Can you hear me?
Yes, we can hear you. Yes.
Yeah. So what happens is ISBAR and all these things can become very challenging to remember what is I, what is S. So like an anesthetist, I tend to go from head to toe. See, A for airway. So in the airway system, whether the patient has an oxygen mask, this, that. B, how's the patient breathing? So I'm coming down from, head to neck to breathing. C, I'm coming to IV cannulations, what the patient has. D, I'm coming to, the diagnosis, as in what is the patient, what was the patient's diagnosis and what we did. Then E, I come to environment, tubes and lines and all these things. So it's just my way of sort of making it easy, go from head to toe or toe to head and look around. So something like that becomes a little easy. I tend to draw a little figure and I tend to do that. So it becomes a little easy. That's what
and it's working for you. It's working for you.
It does, ma'am. It does. It works for me, as in I find it easy to remember head to toe, so I don't miss anything. And of course, it's a principle of the advanced trauma life support also, where you see a patient from head to toe, front to back, like that. So you don't.
I was about to say probably it's more like your assessment tool then of the patient, so that you can immediately make sure that these needs are looked after. I get your point. So when it comes to actually handing over, So when it comes to handing over, I think a lot of tools we have heard of. ISBAR, SBAR we have heard of, SOAP we have heard, Ambit we have heard. So let me quickly share a couple of tools for everybody's understanding, especially for those of us who have not heard of tools of handoff. So this one tool that I'm going to talk about you is SBAR, which is actually the original to start with, and then people added I to it, and this became more clear also when it comes to SBAR. Then sign out is one, and I pass the baton is one. So SBAR, in a very simple ways, that when you are communicating, you just tell what the situation is, which includes patient's details, that is the identity and the other aspects of the patient, and then describe your concern, because you are immediately calling somebody for a reason, that this is the reason I'm calling you. You provide some background under B, so that the person can recollect which patient are we talking about, or what this patient's significant history is. So it could be like the patient is diabetic or hypertensive, or is on this drug, or is investigated for this. So when you provide this background, the other person is able to link, okay, we are talking about this patient. And assessment is, what is your assessment of the patients? That means, what have you been able to observe? So this could be like, what is your clinical impression, or what are your concerns, what are the vital signs or early warning signs that you have been able to observe. And recommendation is like, what exactly do you suggest, or you're actually asking them, what can I do to make things better? So this is usually, for example, people are using, for example, it's a patient admitted for cataract surgery and patient is both diabetic and hypertensive. So you are telling about, okay, this is a patient has both diabetes and hypertension. So that means you are giving background and your assessment is diabetes is under control, but hypertension is slightly, the BP is slightly on the higher side. So what do you recommend? Do you recommend surgery, or you say, okay, we'll wait till we are able to bring the blood pressure in a near normal range so that we can operate this patient? So this is one tool you will come across when you will be seeing people handing over and taking over. The other tool which is very common, and that's called ISBAR, which is actually an acronym for introduction, situation, background, assessment, and recommendation. So you can see majorly I has been added into it with the idea, because when you are actually telephonically, for example, speaking to somebody, you need to tell who you are, about whom you are talking. So I has been added to make it more clear that who is the person who is calling to tell about this patient. So in I, you are actually identifying yourself and from where you're calling. So you need to tell the name and the name of your number of your unit. And then you have to tell about the patient. So now this is about the patient. Tell the name of the patient, bed number, room number, diagnosis, so that they know the person on the other side can immediately relate which patient you are talking about. Then when you talk about the situation, probably you are trying to focus on what is the present problem. So it could be change in vitals, change in mental status, patient is unstable, or for example, you have given blood transfusion and this has happened, or you started a new medication and the patient had some allergic reaction, or some pre-operative observation. All that will be part of the situation. That means what is the immediate concern that you want the person to understand. So what is your present problem? So when you talk about background, the idea is to let that person know about this patient little more so that they can take a call, how important or how urgent is the situation. So in this background, you are going to give information about what is the pertinent medical history, like diabetes, hypertensive, allergic, or if patient had any sensory impairment, family location, or for example, this patient has no attendant or he has a lot of attendant waiting outside, religion, culture, interpreter required, valuable depositions. That will give the other person an idea. It will give a more holistic picture about the patient, and it will help them take a call in a more objective manner in totality. So when we say talk about A, that is assessment, that means what is my observation or the issues I am concerned about. So it could be vitals, it could be the present condition, it could be sensorium, maybe severity of pain, bleeding, swelling, critical lab report, skin condition, risk factor, it could be anything. So that means what is my immediate assessment on which I want the person to take a stand or a call. And last one is R, that is recommendation and request. So specific care required immediately or soon. So that means, do you want something to be done immediately? So what do you recommend? Some painkiller, or maybe some IV fluid, or maybe some anti-allergic, whatever is your recommendation. Or you also ask, what do you want me to do by the time you come in, or by the time you can come? So that's ISBAR. Now this is one exercise I want you to do on ISBAR. Will you try your hands? If you try to, you can take a screenshot of this, or if you want, I can put this case in the chat box. I think that will be better. Give me 1 second to put this case in the chat box. And then try your hands at ISBAR. So do you want me to write ISBAR, full form of ISBAR also? Somebody could please reply if you want me to put ISBAR full form. Okay, I'm doing it. Yeah, I think I'll do it. Yeah. Especially for those who are doing it for the first time, it's easy to, I'll just copy paste it here. Yeah. Yeah, that's the full form of ISBAR. So try writing the case in the form of ISBAR. Case I have posted already, Dr. Sheetal. I put, yeah, it's right here. Go up in the chat box, you'll find it. So like you can see, even we are finding it hard to actually put this thing in a format. Definitely initially it will take time because we still need to understand what will go under what. But once this will become a way of doing it, then it will be very easy and people will know what we need to really report to the next person. So I can see a couple of you have done, you have tried your hands. Introduction, Mr. Rajesh. So Shahrukh, Vijay Kumar, where is your introduction? Who are you? Suppose if you are calling, it's more like you are calling another doctor in the other unit. Then first of all, you need to tell, who am I? Is it a nurse? Is it a doctor? What is the name? Which ward? Which department? So that's what exactly we are trying. I is for not only patient's identity, but for us or for our identity also. That's the whole idea. Yes. Again, see, we are telling what patient is Mr. Rajesh, 50 years old, has minor injuries. Who is reporting? To whom? In SBAR, why they added I? Because give your introduction also, so that the other person knows clearly whom am I talking to. Is it the nurse? Is it the doctor? Or who it is? Not This is just one idea I'm sharing with you. You can design your own ISFAR. So this is the same case. So hi, I'm Dr. So-and-so, resident on emergency ward 2, or nurse so-and-so, resident in emergency ward 2. Then the situation is, I would like you to come and see Mr. Rajesh, 50 years old male, on bed number 3. He's complaining of diplopia in the right eye. Now you're giving a background that this is a road traffic accident case brought an hour ago by the police. He has multiple minor injuries all over the body with no apparent grievous injury. Your assessment is his vitals are stable, but seems to be slightly confused. And our recommendation or request is, will you be able to see him at the earliest? Meanwhile, what would you like me to do? So that's one example of ISFA. But more we will do it, I think more pro will become at it. And it's very important to know what will go where and how to concisely give some information in a very clear, complete manner. So those 7 C's of communication will come handy here when we try to put this information in this format. So this is another exercise. I think you can take a screenshot and try your hands at it. And but we will not do it further because there's some more content to be covered. And then we had 3 presentations also. Okay, so going further, another tool that you may have heard a lot of time is I pass the baton. It's again an acronym. I stand for introduction, that is introduce yourself. P is patient's name and patient's details. A is your assessment, the immediate problem or the procedure that you want to talk about. S is the situation, that is the current status, and also the uncertainty of recent changes that have happened. The second S is for the safety concern. So that means if there's something that you want an immediate attention to. Baton would be to share the background, which includes the comorbidities, like previous episodes of anything or current medicines or family. A is for actions. What are the actions to be taken, and brief rationale for the actions. And then timing is what is the level of urgency or explicit timing. Can you come immediately? This patient requires immediate attention. So that's like a level of emergency or prioritization. And then O is for ownership. Who is responsible? Whom do you want to face the responsibility to take action? It could be the person to whom you are talking to. It could be the team. It could be the patient or the family. And then finally, next, what happens next, or anticipated changes or contingencies that you want to talk about. So, but I think more than this, ISBAR is being used more often in most of the hospitals, like wherever I've interacted. So these are a couple of other reporting tools like SOAP. When you're writing your patient's details, it's a good idea to first write the subjective data, which includes the symptoms, past history, and allergies. Then objective data, which is your examination and vital signs. Assessment, that is clinical impression of the patient that you have, and then plan or the plan for management tool. There's another reporting tool for injury, which is MIVT, which is mechanism of injury, injuries noted, vitals, and treatment. So the idea is, if you have more, structured communication format, it makes sure that you don't miss on anything vital. So when you are communicating, the checklist that you need to follow is the person with whom you are talking. It's very important to get that person's attention. A lot of time the other person is distracted or is doing something. So there's a possibility the actual communication may not happen. So get the person's attention, make eye contact, preferably do it face to face. If not possible, at least, on phone also, you may confirm, is it a good time to talk? Are you comfortable to listen to me? So maybe the person is busy doing something, so person will not be able to attend to your thing. So, but when you're in person, make eye contact and face the person. Use the person's name to get attention, express your concern, use the communication technique like ISWA that we have talked about, reassert if necessary. So if you think that I need to really, in the end, say, I think you need to come urgently. I think you need to send your resident. I think this patient requires attention. So you are kind of reasserting, you are kind of very clearly communicating what is the need of the hour. Then a decision is reached when you talk to the person says, okay, I'll come, or I'll come in half an hour, whatever you agree. If everything is okay, fine, otherwise escalate. That means you need to speak to the next person so that this person gets the required attention. So that's something that we really need to follow. Now, talking about the benefits of standardized communication, why have a format? Because format is important. The benefit is it focuses on the patient and not on the people who are handling it. Because if I don't have a standardized communication, I will use the style of communication that I enjoy most or I'm more comfortable with. So there will not be any uniformity. Standardized format will allow the parties to have common expectation. What is going to be communicated? So if I know we are using ISBAR, I know after I, you are going to tell me situation. And then after situation, you will tell me the background. So I will not interrupt you. Who is this case? Tell me more about it. I know after situation, you are going to tell me about the background. And then you're going to tell me your assessment also. So if you have a format, you know what is going to be communicated and in which order. And also the person who is communicating will know, okay, I'm supposed to be telling these things in this order. So it makes communication more, productive and also well understood. If you're planning to implement handing over tools in a very, very systematic manner, there are a couple of suggestions that can really help you in making sure that this actually happens in real sense in your setup and not remains just a eyewash or a more of a note making kind of a activity. So first of all, assess all points where handoff occurs. So visit your hospital, see where all handoff occur. Then at the same time, concurrently monitor process at all points. How are they doing it right now? And then conduct the gap analysis. What is the right way of doing and what they are doing? And as a result, what do you think is actually, how is it affecting the actual handing over or the outcome or patient safety concerns or quality implementation? It could be anything. So whatever the gap analysis are, identify those gaps, then identify people who can actually work as your champions. So when you will say, okay, we want to implement handoff in real sense, people will not come forward totally. So you'll have to identify people who can be your champions. It could be the physicians, it could be the nurses, it could be the even leadership who buys your idea. So once you have them in, they agree that, okay, we'll cooperate, we'll try to implement, we'll try to follow your instruction, then is the time to actually select a consistent approach that you are going to implement after having brainstorming and after finalizing the list of at least minimum communication that you need to make. Then develop a policy and a procedure. How is it going to be done, where it is going to be done, who is going to do, what all you need to follow, all that you will have to have in place. Then educate your staff, whatever you have planned or kind of decided. Let them know how exactly you want them to implement your handoff policy. Educate them and then implement the policy. Monitor and report findings. So naturally, when you will start implementing, things will not automatically fall in place. There will be bottlenecks, there will be issues, there will be problems that you need to really, address right from the beginning. So it's good to supervise, monitor how they are doing it and what, gaps still you observe. And then you need to keep updating the procedure. For example, you think, okay, this was not okay, I think we need to talk about this, or maybe this element needs to be added or needs to be deleted. All that can be, implemented into the actual protocol that you are going to do. So the benefits, if I talk about the benefits of proper handover, once you will start implementing, you will see there will be less lapses in care. There will be continuity of care, patient safety will be ensured, you will see less sentinel events you will experience. There will be decreased errors in patient care. I have a study I should have brought in here to tell you that these were actually observed. They studied around 1,074 patients who were actually handed over, following proper ISBAR protocol. And all these things, they were able to see that there was better continuity of care, patient safety was ensured, less sentinel events. It led to decreased error in patient care and decreased repetition, even reduced the cost of the treatment and also the stay in the hospital. And as a result of all this, there was definitely increased patient satisfaction. So the take-home point from that I want you to remember, 80% of the errors in patient care happen due to information loss because of ineffective handing over. That's the importance of handing over. I need to understand that if I want to ensure patients' continuity of care and patient safety, handing over has to be implemented in real sense. While giving handing over or handoff, please be specific, concise, and deliver the information in a standardized format. Use some format, even if it is 5P, it's okay to start with. Slowly you can make it better, and you can incorporate more issues and more topics, but then it has to be in a standardized format. And the person who is receiving the format has to make sure that the person is listening attentively and also noting down the points that you need to note down, or if you have questions, please ask. And then in the end, make sure that you read back. That will automatically make sure that your information is completely well understood by the person who is taking over. So this is in a nutshell about handing over as an important tool. And this is an important topic also for the training of your staff. It should be introduced to them so that they understand the seriousness of this activity in real sense, and that needs to be implemented. Any questions about what we have discussed? Or any thoughts or any experience that you want to talk about? What challenges have you experienced when you tried implementing it?
Ma'am, I see that sometimes what is happening is it is a requirement through standards that handovers have to be written. So imagine that there are about 15 or 20 patients and the handover has to be written. So we tend to see that, it is lots of times a cut copy paste is used. The important information is lost. We did try to implement this S-bar thing, but somehow the understanding is not very robust. Yeah. We've tried this exercise, and we've also tried things like make it short and sweet. But sometimes, because I think a lot of information, ma'am, is lost because of our persistent sort of insistence, let us say, to documenting. Unfortunately, I think it leads to a lot of fatigue among healthcare workers, because that dictum now is, unless documented, it's not done. So I feel that pressure is quite a bit on healthcare workers, and sometimes I may just forget, like you said in previously. So somehow I feel that there has to be a via media. Sometimes I feel that our healthcare workers need to be sensitized as to what is important, and how a handoff can be also verbal as well as written down. If it is both, I believe that it can be definitely more effective, that kind of a thing. So
I completely agree with you, Dr. Sheetal. I think that's a major concern that healthcare professionals now say we feel like we are more clerks than doctors and nurses. I don't deny this fact. But at the same time, if I'm not able to mindfully communicate what is very salient about a patient, that will not be pardoned for any reason. Tomorrow in the court of law, I will never be excused for this reason that I was overoccupied or I had a lot of information to handle. Whatever the reason I give, if I know this patient is diabetic and can go into hypoglycemia or has inconsistent, sugar levels, it's my duty to make sure that I communicate because it's a life risk. It's my duty to communicate to the next person, even if I have to write that in red ink, that this is a problem. And there has to be some internal communication designed. I am not saying apply ISBAR or SBAR or I pass the baton. I'm not saying, maybe their style of communication is very different. Things are much more evolved in their country. I'm not saying, but have some system, have some structure, make them responsible to communicate. Of course, documentation, if it is not 100%, at least the minimum what is required, if it is communicated, even that is done. But if I don't communicate at all, if I don't write it, if I don't verbally communicate, then I'm failing in my duty. And then I am legally responsible for that. So you will have to really strike a balance between these things. That what is most essential to be communicated, at least should be communicated.
Yes, I totally agree with that, ma'am. There is no question. There is no excuse to no handing over and thereby, because like you said, 80% of the problems do occur because of this no handovers and all that. But yes,
Absolutely.
there there has to be that. Unfortunately, our healthcare workers are also so overburdened that so many times there is that
सुनो एक बात बोलूं, एक मिनट मैं अगर पिछला वाला मुझे याद है last time Mr. Mohan, when he brought up this case to discuss that Chinese whisper, he said no, it's not Chinese whisper. It was, what was that topic that you gave? It was not Chinese whisper, Mr. Mohan.
Telephone game.
Telephone game. So if I looked at that case when he brought it to me and he said it's a real life case and I have handled this case, instantly I had a thought, if the patient was complaining of numbness, it's a serious thing. It's not a small thing. If I am the resident on duty or if I am the nurse on duty and if I have sent the referral, it should stay in my mind that this is important and the doctor has not come. The doctor who had gone traveling, it was his duty to follow up. Has this patient been attended or not? See, if I'm operating a case and if I say I've operated and I'm done with it and I'm going for my thing and that's not my responsibility, again, patient is under your care. So these are the calls individually we have to take, how much ever burden we. I'm not saying do everything blindly, but then what needs to be done has to be done. You have to find ways to do it. I mean, you can't afford to miss on this critical communication. 16 hours later, the neurologist comes to see the patient. I mean, imagine that you remember that, what is that model called? Swiss cheese model. When everybody fails, then error happens. Everybody failed. The nurse failed, the resident failed, the neurologist failed, the surgeon failed. Who ultimately lost? It was patient. 21 years old young boy. It could be your family member or it could be my family member. I mean, any amount of explanation cannot justify this. That's what I want to say. I'm not saying इस बार follow करो, इस बार follow करो. आपकी अपनी जो situation है उसके हिसाब से एक critical communication जरूर जाना चाहिए. चाहे मुझे उसकी फाइल पर रेड पेन से लिखना पड़े, ये पेशेंट डायबिटिक है और इसकी फ्लक्चुएटिंग शुगर है, प्लीज अटेंड टू दिस पेशेंट. जैसे वो केस शीट मेरे सामने आती है, मुझे देखना है कि इसकी शुगर तो ठीक है कि नहीं, बाकी सब चीजें बात की है. Can we develop that kind of a communication? To the point. It could be our internal communication. Forget about the documentation part. It is our internal language. That's what I'm trying to bring your focus on. I'm sorry I interrupted you, but because I was really overwhelmed when Mr. Mohan shared this case with me. I said, everybody failed. मैंने फाइल में लिख दिया, फोन पर पूछ लिया, उसने कहा अर्जेंटली बुला लो. अर्जेंट का मतलब क्या होता है? अर्जेंट का मतलब होता है कि it has to be done. It has to be done. How I do it, that's my responsibility. If I'm on duty, it's my duty. मुझे जाकर बुला के लाना पड़े तो भी कोई बात नहीं, because it's something serious. और उस डिपार्टमेंट में जो डॉक्टर्स और नर्सेस काम कर रहे हैं, उन्हें पता होगा कि दिस इज वन ऑफ द पॉसिबल कॉम्प्लिकेशंस. I'm sorry for, I mean, actually I was very upset when I got to hear this case. I said, we all failed. And that's what happens. Errors happen when everybody fails. When everybody fails.
Ma'am,
yes.
In your presentation earlier part, you said that with the JCI hospitals, JCI accredited hospitals have, I mean, and the percentage of errors, communication errors were quite high. And JCI is considered one of the best accreditation as far as I know. Even the JCI hospitals are having so much of communication errors So how can we expect improvement in our scenario?
Having JCI, having NABH, and actually implementing it has two different aspects.
That means
unfortunately we all actually think that it's all paperwork. एक कंसल्टेंट हायर करेंगे, वो NABH के सारे डॉक्यूमेंट्स तैयार कर देगा, फाइल लगा देगा और मेरा एक विजिट होगी, विजिट के दौरान में मेरे सारे स्टाफ को ट्रेन कर देगा और NABH हो जाएगा. ऐसे ही JCI के बारे में हम सोच कर चलते हैं. But it's a journey. It's everyday action that needs to be taken. Probably यहाँ हम fail कर रहे हैं. I would say NABH or non-NABH, I need to know that everything happened under my, care is my legal responsibility. And I have to make sure that things function in the right way. I don't care JCI, non-JCI, but then, the person who has to face the music is ultimately you and nobody else. जो challenges हमारे वहां पर है, वही challenges इन लोगों के पास यहाँ पर है. हालांकि ये लोग इतना meticulously काम करते हैं, but even then I see there is a disconnect, there is a communication gap, there is no proper, flow of information from between two cadres of people or two departments and two consultants. और ego problem वहाँ बहुत खुले में दिखती है, यहाँ subtle way में दिखती है. सब कुछ है, सब कुछ है. Everything is more or less same. Mr. Mohan, I think you wanted to say something.
No, ma'am, nothing.
Okay.
Thank you.
So if there are thank you. So if there are no more questions, can we quickly have the presentation? I think we have Dr. Shahrukh and Dr. Rajesh Talwar. और कौन है आज की presentation में?
Did I miss on something very important? I joined a bit late.
About this session, I think
yes.
एक बारी video देखना. I'll share the YouTube recording. Please. We shared couple of cases in the beginning, real life cases I brought in to show where the lapses in care happen just because of improper handing over, and we lost the patient. It's not just the any sentinel event, but actually patient lost life. So that's the seriousness of proper handing over we talked about. But please look at the video in case you missed something in the beginning. So I think I'll request Dr. Shahrukh to first do the presentation. Dr. Talwar, there's a reason why I want you to second, because your presentation and Shahrukh's presentation have interlinked. So it'll be good to have your presentation as a second presentation. And I can also see some of you have not responded to the call of doing your presentation. I understand there must be challenges at your end. Maybe you're occupied, maybe you don't have time, whatever. But at the same time, it's your call, because I thought that this way you will be able to practice your skills. But I completely understand you may be having multiple responsibilities to look into. So we have 2 more sessions to go. And those who want to really present, they can write in the group that they will be presenting, so that I know and I don't follow up with everybody. And you just let me know that, yes, I'm going to present. And then accordingly, we can decide about the timing also, because it takes a little longer when we have multiple people presenting. So Dr. Shahrukh, I have given you the access to share your screen. Please check if it's working for you. Yeah. Yes. Yeah.
Is it visible, ma'am?
Yes, we can see your screen. Thank you.
Okay. So I'm going to show a video. I'll just check it once if the audio is coming or not. I'll just play it once, then I'll start it over again.
Your knee joint is made up of the lower end of the femur.
Yes, we can hear.
Okay, ma'am.
Yes, we can hear. Yeah.
So I will show this video and then ask some questions from the participants.
Just 1 second, Dr. Vanshimo, Mr. Vanshimo is saying that Shahrukh is not audible. शाहरुख थोड़ी आपकी शायद हो सकता है आवाज कम आ रही है.
Hello, is it audible now?
To me it is audible. I think others need to now tell. Everybody is saying not audible.
Could you please speak up again so that?
Hello.
Yeah.
Am I audible?
Now you're audible.
Okay, thank you.
Yeah. So maybe you were away from the mic. The volume is low. Yeah.
So I'm going to play the video now. Hello. So the questions for all of you are, what do you think this video was all about?
Knee replacement surgery.
Yeah. So the next question is, have you ever heard about it earlier? Most of you.
Yes.
Did you have the clarity about how it is done? Okay. So has the video helped you in developing any clarity about what happens in this procedure, apart from what you knew earlier? Okay. So good evening all of you. I am presenting how to use videos as a way of effective facilitation. As you would have heard that a picture is worth 1,000 words, which means a picture can make you understand the whole story. So it is obvious that moving pictures in succession with the sound are will be way better, and we will be discussing how they enhance our understanding of difficult things. So what are the benefits of showing videos? So we can show things that are very hard to imagine otherwise. Videos are engaging and entertaining. They improve our learning, and same content can be delivered to different groups. The quality of content will not change if you show the same video to different groups. The other benefits are they are great for auditory and visual learners, and more videos are being added daily to the clouds like YouTube, and technology is becoming cheaper. And through this, the educational videos are reaching more people. So the sources which can be used can be made by the videos can be made by the presenter, or it can be taken from an external source like YouTube. So how will you choose an ideal video for a topic? It should be relevant to the topic being discussed. It should be interesting. The video should be short. The sound quality is more important than the video quality. We have to remember this. The content should provide what it is supposed to provide, and the source should be readily available for the revision of a concept. So what type of videos are actually required? So what the participants who are going to watch the video don't want. If you don't introduce the video, if they don't know what is the relevance of this video pertaining to the topic which is being discussed, if the video has a poor sound, if the video is halting while it is being played, long videos, and if the links are not readily available, usually the participants don't want these kind of situations. And what does the participant want? So this part of the both slides will be discussed in detail by Dr. Rajesh Talwar. That will be the next presentation. I am just going to touch upon the topic. And the participants want, there was a study from which I have taken all this. So it said that the participants want that they should be alerted before the video is being started, and they need to know why it is being shown, and the video should smoothly integrate with the class material and whatever is being taught, and there should be a debriefing after its completion, and the presenter should discuss the main points in the class after the video is completed. So in a lecture, only 10% of the class time should be taken which should comprise of videos. 2 to 3 videos are preferred over a single video, and a longer video, and less than 5-minute videos should be taken. What are the problems for which we should be prepared before presenting videos in our lectures? Some of the problems are unfamiliarity with the equipment, incompatible installed software, sound driver which does not function sometimes, internet access can be a problem, and device incompatibility. So there should be a backup plan for sound and internet, and the presenter should familiarize with the equipment and software. That's all. Thank you.
Thank you. Thank you, Dr. Shahrukh. I think you were to the point.
Thank you, ma'am.
Thank you. Even I find using videos very useful way to explain some concepts. For example, when I talked about selective attention, it would have appeared more like a abstract topic. But when I showed you that video of where we actually miss the attention, immediately you got an idea, okay, that's how we miss on vital information. Thank you, Shahrukh. I think it was a very well done presentation, to the point. Thank you. I think Dr. Puneet, your question is answered. What should be the ideal duration of the patient education video? Not more than 2 to 3 minutes. You know, attention span, especially with the younger generation, is going lower and lower. Somebody was telling me it's less than a minute now. So therefore, you see TikToks are hit. Because very quickly it conveys the message and it disappears. Thank you. So can we have presentation by Dr. Talwar? So that brings in your topic very well, Dr. Talwar, because that's why I said that you will present after Dr. Shahrukh.
Screen is shared.
We are not able to see your screen. It is not shared yet. So you'll have to go down to screen sharing. Yes, we can see now.
Good evening, Dr. Indu and all my dear colleagues. First of all, watch this video. So I would request all of you to kindly show how did you perceive this video. Either you can unmute or you can put in a chat box. I didn't get any answers. So I'll now tell you, like millions get affected by the contaminated hand transmitted infections, and it can lead to serious illness, tragic loss of life, additional cost, prolonged stay in the hospital, long-term disability, increased resistance to the antibiotics. Hand hygiene is most effective intervention to reduce transmission. It's simple, cost-effective, and saves lives. But to your surprise, adherence is only 39% worldwide. Now I'll show you another video. So may I request you to just let me know now what is your perception? Why it is necessary to wash hands? Could you tell me the reasons and where all we can it is necessary in what situations? You can unmute and just let me know. Or what are the other alternative ways of sterilizing hands?
We can use sanitizers.
We can use alcohol-based hand rubs. We can use What other methods we can imply to reduce the contamination through hands? One thing we know that we can use alcohol-based or we can use water, but what other methods we can use to to give training to the staff or to educate them? So we can use some visual reminders to the staff. We can use promoting and supporting patients, health workers, safety culture we can introduce. And where all do we require to wash our hands like this? Yes, anyone?
After every touch point of the patient.
Yeah, definitely. After touching the patient, even before touching the patient, you should wash your hands. Any other condition? We do all the aseptic procedures, there also we have to wash our hands like this, or even we touch the surroundings of the patient, even then we should wash our hands. Or even after the body is exposed to fluids of the patient. So in that case also we do. So the whole purpose of this exercise is like when I showed you first video, I didn't say anything about that video. So there was less perception of what we are going to do because everyone washes hands like this and everyone knows the steps. So what is new in this video? Why I am showing this? But when I give you small briefing about the video, so in that case, something starts processing in the mind, like this video is something about very important thing because the serious illnesses arise from that, or antibiotic resistance is caused. So we have to see this video carefully. And what after the video was second video was shown, I just wanted like uh, uh, your feedback or your views, like why we should wash our hands or where should we wash our hands. So my topic is briefing and debriefing in demo. So what is briefing? Briefing is a very short and concise summary of a situation, and this information basically flows in one direction, from me to you. What is the purpose? So as I told you, like it maps out the plan of the care in the patient. Second is it identifies roles and responsibilities for each of the member who sees it. Third is it heightens awareness of the situation to each participant. Fourth is it allows the team to plan for the unexpected. Five is it anticipates team members' needs and expectations. In briefing blueprint, first is briefing structure, which should have a start and finishing with important points. It has a briefing content. It focuses on what and not on the why. Third is briefing clarity, performance, that should speak the audience language. Then in briefing content, you will have much more information than you can or you should brief. Always prioritize the information. Whatever you want to speak, you should have a always set the priority in giving the information. Then give only what is needed and avoid over briefing. What is the effective briefing? Setting of the tone is very important. Keep briefing organized and efficient. Encourage audience. What should you always do? You should always keep it brief. always get directly to the matter. The language should be clear. Very few words and concise sentences should be used. The explanation should be clear and direct. State the situation and discuss that potential resolutions. What you shouldn't do, you should not go very fast. In debriefing, it's a simple, powerful tool that enables participants to reflect on what happened during a session and why it happened. The events are fresh in the mind now, and so that the gaps in the knowledge and performance can be identified. Debriefing is stop talking at the people, but you are talking with the people now. Invite the people to your conversations. What do you think is the other ways to clean your hands? The debriefing should have a direction. It should have a clear intention and knowledge and skill based. What are the advantages and disadvantages? The advantages of debriefing are the facts are reviewed. You always review whatever has been shown to you. Now, it's the audience chance to respond on what happened and why happened. The misconceptions, they are corrected. Valid, fair observations taken on board. What disadvantages are, like not all the participants can be entertained, because if I have a huge participants, then each of them cannot be entertained. Thank you. So no action, if there is no action today, no cure tomorrow. That's a basic message. Thank you, everyone.
Thank you, Dr. Rajesh Talwar. So we use briefing and debriefing in simulation-based teaching learning. Absolutely. I think by briefing, you set the tone, you set the purpose of the demo or video or activity so that people know what they are going to do and why they are going to do. A lot of time you will see trainers would do activity or some, action, but they will not tell you what is the purpose of doing it. So I think briefing and debriefing helps to know why we are doing it and what has to be the, observation points. And of course, debriefing will help us in thinking critically. I think Dr. Rajesh Talwar asked a lot of pertinent questions after the video. That was much way beyond the content of the video. But then you asked a lot of questions to stimulate that thinking that, okay, what are the other ways besides washing hands to prevent infection, and why we need to, wash hands, so that it's not just to protect the patient, but protect us also and prevent the spread of the infection. I think wonderful presentation. Thank you, Dr. Rajesh Talwar. Thank you. I know it's already almost like 25 minutes past 10. I've pasted the feedback form in the group, not here, because I don't want to hold you further. I will request everyone to give your feedback about this session, not about the presentations, but about this session on handing over tools. And then we meet next Wednesday for the next topic, and then one more topic in the coming week. Should we close it here? I don't want to hold you further. That's why I'm trying to quickly. Thank you so much, everyone. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Good night.